Good evening and welcome to tonight's installment of our Cancer's Health Education webinar series. I'm your host, Joan Heimbrook, Community Outreach Coordinator for the Franciscan Health Cancer Center in Indianapolis and Mooresville, and I'm excited for our team to share some great information on this evening's topic, cancer in women. This evening, our expert presenter will discuss the most common cancers in women, risk factors for female cancers, as well as prevention and early detection strategies. Now, before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted, and we ask that you remain muted to help us avoid background noise and interruptions. If you have questions to ask our expert during the presentation, please type them in the chat window. We'll be answering your questions at the end of the webinar. Kirsten is our administrator. She'll be taking care of everything on the back end, so if you experience any technical issues, just type them in the chat window, and we'll work to resolve them. And if you miss anything, no need to worry. We'll send out the recording of tonight's presentation to you in a follow-up email, along with some great resources for you to download on tonight's topic. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. And tonight I'm excited to introduce to you Dr. Naina Mahngar. Dr. Mahngar is a hematology oncologist with the Franciscan Physician Network at the Franciscan Health Woodland Cancer Center in Michigan City. Born in South Bend, she graduated with honors from the Indiana University School of Medicine and did a 6-year residency and fellowship in medical oncology and hematology at the University of Illinois at Chicago. Dr. Mahngar and her husband enjoy the great outdoors and love taking their golden retriever on trails and to the beach. Her hobbies include cooking, scrapbooking, working out, and of course, her dog. She's passionate about women's health, especially breast cancer, and she and her husband are expecting their first child in February, so congratulations are in order. Now, before we get started, let's get a better understanding of who our audience is with a poll question. Why are you attending this evening's webinar? A, I want to learn more about the risk and prevention of certain female cancers. B, I know someone who has a female cancer and want to learn more. C, I have or have had a female cancer and want to know more as a survivor. Go ahead and plug in your answers. Okay, it looks like we've kind of got a little bit of a tie between A and C, but it looks like we have a variety of people here who want to learn a little bit more about cancer in women. So now, without further ado, please welcome hematology oncologist Dr. Naina Mahngar as she discusses the latest information about cancer in women.
Thank you so much, Joan, for that introduction. And I want to thank everyone for coming tonight. I am very passionate about women's cancers. I would say probably 30% of my clinic currently in Michigan City is breast cancer survivors and patients with active breast cancer. And so I'm just really excited to do this talk today and talk to you all about women's cancer. So if you do have any questions, please put them in the chat. It's a very open dialogue, and I hope that you all kind of walk away having a little bit more information today. So one really shocking statistic is that 1 in 8 women will be diagnosed with breast cancer in her lifetime. So, I remember learning this statistic in medical school and just being shocked because we all know 8 women, we probably all know 50 women. To think that multiples of them will be diagnosed with breast cancer is a pretty shocking statistic. And I think for that reason, because it is so common, it is something that I think every woman should know about, knowing her individual risks and ways to minimize those risks. So currently there are about 3.8 million women living in the United States that are breast cancer survivors. So if you look at our population of somewhere between 350 and 400 million people, almost 1% of the population are breast cancer survivors. So it is a very large cohort of patients. And as we saw in the poll, multiple people here, almost half of the audience are breast cancer survivors themselves. So let's talk a little bit more about breast cancer and the recurrence rates and the death rates. So if we look at the new estimated cases on the left side, you can kind of see that breast cancer is at the top. And so this statistic is from the American Cancer Society in 2013, but it's still fairly accurate. So it's almost about 250,000 patients are diagnosed with breast cancer. Women are diagnosed with breast cancer each year. And if you look at the percentage of new cancers, that is about 30% of new cancers in women are going to be breast cancer. And then if we look at the estimated deaths on the right side, you can see that about 40,000 women pass away annually from breast cancer, which is about 14% of all cancer deaths among women. Now, I will say in 2007, the mortality rate from breast cancer per year was closer to 90,000. So this number has gone down significantly. And we'll talk about why, in a little bit, but we can see there's almost a 50 to 60% reduction in deaths annually from breast cancer. But clearly with still 40,000 deaths every year, we still have a ways to go in terms of treatment and management.
Okay, so those are some astonishing numbers, and thank you, Dr. Mahngar. Now, before we move on, let's test your knowledge with another poll question. Which of the following is a risk factor for breast cancer? A, age, B, obesity, C, smoking, D, all of the above. Wait for your answers. Oh, you guys are smart. The answer is D, all of the above. Among others, age, smoking, and being overweight are all risk factors for breast cancer. And here's Dr. Mahngar to tell us more.
So let's talk a little bit about risk and prevention of breast cancer. I'm happy to see that almost 95% of the audience answer that question right. That's great. So we'll kind of talk about multiple risks for breast cancer on the next slide. All right, so the most common risk factor that we're going to see for breast cancer is going to be female gender. Women have breast tissue, and so breast tissue itself is going to be the risk for breast cancer. So what happens is as we get older, breast tissue is always changing and evolving, and those cells are always turning over. So as we get older, women are more likely to have more mutations or error in their breast tissue, and that is an error in a cell is what causes cancer, or at the fundamental area. So being a female is an increased risk. Now, it doesn't mean that men don't get breast cancer. It's uncommon, but about 1 in 1,000 men are diagnosed with breast cancer. So it's not similar to that 1 in 8 number, but it's still definitely possible for men to be diagnosed with breast cancer. While they don't have large breast tissue, they do have some breast tissue above their pectoralis. So it is possible, it's less common, and male breast cancer makes up about 1% of all breast cancer. So again, being a female and having breast tissue is what increases that risk. The next thing that increases the risk is age over time. And this is not just for breast cancer, this is for many types of cancers, but basically as we age, again, the breast tissue, as it's making more changes and turning over and more cells are turning over, the older we get, we're more likely to have an error or mistake made, because that perfect system, can acquire errors over time. So most breast cancers are actually diagnosed over the age of 60. And in fact, almost 40% of breast cancers are diagnosed in women over 70. So while breast cancer can occur at any age, it's uncommon to happen really before the age of 40. And again, over the age of 60 is really when that risk goes up. The next thing that we know increases the risk of breast cancer, and this is a little bit more of a question mark area. We're still learning a lot about genetics. So family history or having a first-degree relative with breast cancer increases a woman's risk. So that means if your mom, sister, or daughter had breast cancer, you're at increased risk. And the risk is about twofold in family members. Now, what I will say is almost 70% of women who are diagnosed with breast cancer have no family history. So while family history can increase the risk, it doesn't necessarily correlate to the numbers of breast cancer that we see. And a lot of women have no family history that are diagnosed with breast cancer. So the next risk is basically how much time there's estrogen in your body. So starting menstruation before the age of 12, starting menstrual cycles, basically means that you're going through estrogen cycle changes every month sooner than other women. So if you start at 8 or 9, that's several more years of estrogen changes that you're having. And what we know estrogen does is it stimulates breast tissue, and anything that's stimulating the breast tissue can increase the risk of mutations. Similarly with menopause at a later age basically is going to have an increased time of estrogen in a woman's body. So women who are menopausal or don't go into menopause until they're 70 or not 70, 60, 65, they have more time with estrogen in their body, and that estrogen can increase the risk of stimulating breast cells to become cancerous. The next thing is very similar in terms of risk. So a first pregnancy or no pregnancies, a first pregnancy after the age of 30 or no pregnancies in a woman's life. And again, this is all about hormone regulation. We know that pregnancy is protective against breast cancer because of how it affects estrogen. And so we know that women who have their first pregnancy before 30, it's protective, and after 30, that risk can go up a little bit. The next thing that increases the risk is dense breast tissue. So density in breast tissues, our breasts are made up of lobules and ducts that lead to the nipple. And the point of, or the function of breasts are for milk production and secretion of that milk. And so dense breast alludes to having more lobules and more ducts. And so basically you have more cells. And again, the more cells you have, the more likely there is for an error to occur. Another factor that increases the risk in these women is that dense breast tissue, it can be a little bit harder to detect breast cancer. Now, it doesn't mean that it's going to go undetected, but a lot of times on mammograms, sometimes women will have to come back for an ultrasound or a second look or 6 months later mammogram, because with some of those breast densities, it's hard to see through what is just generalized dense tissue and what is something potentially more concerning. And then I've kind of been alluding to this kind of all along, but exposure to estrogen is one of the major risk factors for breast cancer. So again, we know that estrogen stimulates breast tissue, and anything that's stimulating breast tissue can stimulate cells to become errorful, basically. And so, you know, about a decade or two ago, we used to prescribe estrogen hormone replacement therapy to a lot of women going through menopause, because as we know, menopause can be very difficult for a lot of women, a lot of side effects, and it really can be a decline in quality of life. And so we found that giving back some of that estrogen that was being taken away during menopause, giving some of that back could help with symptoms. But unfortunately, what we learned in the mid-2000s was that this extra estrogen can actually increase the risk of breast cancer by that same mechanism of stimulating breast tissue. And then another cause of breast cancer, which is similar to quite some other cancers, but lack of regular exercise, increased obesity. And again, obesity is linked to increased estrogen. So women who have a BMI greater than 30 have more estrogen, and that's where that link is. And then alcohol and smoking can increase carcinogens in breast tissue and increase the risk of breast cancer. Now, I will say, while these are risk factors, and you know, women can have a variety of risk factors, we still don't understand why each and every woman gets breast cancer. There are definitely certain things we still don't understand for why it is so common for 1 in 8 women. And as I alluded to earlier, you know, 70% of women diagnosed have no first-degree relative with breast cancer. So it's, which I think is quite surprising. It just shows us how much we still have to learn about how this mechanism works. So I know at this point, a lot of people think about, well, what is my risk? You know, I qualify, I check some of these boxes, you know, what is my increased risk? So on the left side, I put something called the GAIL risk model, GAIL spelled G-A-I-L. And so what you can actually do is, for each individual lady who's here tonight, if you'd like to see what your risk of breast cancer in the next 5 or 10 years is, you can actually put in your information in the GAIL risk model. And what it will do is it will actually ask you all of these questions in a little bit more detail, ask you these questions, and it will give you a percentage of what is your risk of breast cancer in 5 years or 10 years. And it'll compare it to the average population. And if your risk is elevated compared to the average population, and it'll be like a percentage amount. So it might be 1.5 times, or 0.5 times the average person. But if it's elevated to be 1.7 times more than the average population, we know there are some medications we can give which block hormones, or hormone blockade, essentially, that can reduce that risk of breast cancer. So I encourage everyone to put in their information in the GAIL risk model. If you do have an elevated score, or you're concerned about the score that you get, I definitely recommend that you follow up with your primary care doctor, and then they can kind of guide you from there. But that's a great starting point, because again, when you think about 1 in 8 women, we all know 8 women, and so we have to all try to minimize our risks. So now that we've talked about the risks, let's talk about detection. This is probably the most important part of our presentation tonight. And I would say, if you tune out a little bit with some of the heavy facts, this is the time to really pay attention. But we're going to talk a little bit about mammograms in the next slide, and just how amazing they are at decreasing the mortality from breast cancer. So let's talk in a little bit more detail about mammograms and what they are and how they work. So mammograms are basically screening x-rays that we're able to put a sandwich a woman's breast between and kind of look through all that tissue. So we talked about all of the breast cells, the lobules, the ducts. And so we can look through those and basically see, is there something concerning on the mammogram? Now, the reason mammograms have really transformed how we treat and diagnose breast cancer is we're actually able to detect lesions as small as 1 millimeter in size, which is the tip of a pin. And why this is beneficial is, of course, myself and other physicians can do breast exams. I probably do, 10 or 15 a day in clinic because I have a lot of breast cancer patients. But we know that the average clinician cannot detect a mass in the breast until it's about 1 centimeter in size. So mammograms can detect cancer in the breast at 1 millimeter or 1/10 of that. So they can detect things much sooner than a physician can on an exam in the office. And so for that reason, this is really what's transformed mammograms. So we know that for any woman that is diagnosed with breast cancer on a mammogram, compared to if she had just come in because she had felt a mass, the woman who got the mammogram is actually 40% less likely to die from that breast cancer. And that's because the smaller the tumor that we detect, the less likely it is to recur and the easier it is to treat. So we know for most lesions that are less than 1 centimeter, again, smaller than what can be palpated by a clinician in an exam room, those ladies have up to a 98% cure rate and survival rate at 5 years. So really, this has decreased the mortality from breast cancer. It is actually probably responsible for decreasing mortality by 40 to 50% in all women. What we recommend is that all women start getting their mammograms at age 40. The recommendation is for an annual mammogram at this time. For women in their 40s and throughout their 40s, sometimes you can have more dense breast tissue. So sometimes we'll also recommend an ultrasound after that mammogram because the ultrasound can be a little bit more sensitive to kind of look through the areas. Now, one thing people worry about is, well, how much radiation exposure is this from an x-ray? So the MEV is the amount of radiation that's exposed, and it's about 4 MEV that's exposed for 1 mammogram. And if we kind of compare that to the background noise, just living in a developed country like the United States, we actually all experience 7 MEV of radiation a year. So it's a pretty negligible amount. And I would say, again, when you think about that 1 in 8 number, it really is something that is saving lives and very much worth the benefit. I've seen patients in my clinic that their tumor has been detected at 1 millimeter, 2 millimeter, 3 millimeters. I mean, very small lesions that we would not have been able to feel should they have come to our exam room. And so for that, they've done it outstandingly well because they've been found very early. We've been able to operate and then they, move forward. On the flip side, I've had patients who haven't had mammograms done and have come to me with 4 or 5 centimeter masses in the breast. And then that can become a little bit more challenging. So again, I encourage all ladies, it's October, to schedule your mammogram and kind of do your part to kind of decrease your own risk and decrease the risk of a more aggressive tumor. So now that we've kind of talked about mammograms, I also want to talk a little bit about breast cancer types, because this is a question I get quite a bit. So we'll go to the next slide. So you can see this diagram on the left side, and basically we're looking at the parts of the breast and where breast cancer can originate. So as you would, intuitively think, all areas of the breast are places that breast cancer can occur. So on the left side, we see ductal breast cancer. So ductal breast cancer starts in the milk ducts themselves. And so this is actually the most common type of breast cancer that we see. I would say probably 60 to 70% of ladies are going to be diagnosed with ductal breast cancer. Very common, very easy to detect on a mammogram. On the right side, we have lobular breast cancer. So lobular breast cancer generally starts in the lobules that create milk. And then basically the grapes that we're looking at on the image. And so lobular breast cancer is definitely detectable by a mammogram, but sometimes we'll need more imaging if we see something concerning. We'll need some more imaging like an MRI or an ultrasound to kind of further look. And you can kind of see in the picture that these kind of grape-like structures can be a little bit difficult to kind of figure out sizing and things of that nature. So that's why sometimes with lobular breast cancer, we need more imaging. And it's a less common diagnosis, but still second most common. In the bottom left side, we see mixed breast cancer. So sometimes breast cancer can arise somewhere in the ducts and also somewhere in the lobules kind of along the way. In the middle bottom, we see inflammatory breast cancer. So this is something I just wanted to kind of give a little bit more information about. So inflammatory breast cancer has spread to the dermal layer or the skin layer of the breast. and it can travel very, very quickly. I have seen cases of inflammatory breast cancer where, there'll be a 1 centimeter little rash, what looks like a rash on the breast, and it will spread and travel, within 2 or 3 weeks to the entire breast. So for all women, especially women over the age of 60, if you do see any new lesions or rashes on your breast and they don't go away within a couple of days, I would definitely get a hold of your primary care or be seen in urgent care, because a lot of times inflammatory breast cancer is misdiagnosed because it looks just like that. It just looks like a rash. And so people don't think anything of it. But any new rashes or lesions on the surface of your breast that aren't going away, you definitely need to see a provider for, because this type of breast cancer, because it's on the top layer, can actually spread really quickly. So it's just one thing to kind of be mindful of. And then to the right, we also see mucinous breast cancer. So very uncommon. Mucinous cells are basically supporting cells in the breast. They support the ducts and the lobules. And so sometimes these can become cancerous. Very uncommon and usually grow very, very slowly, but also a type of breast cancer. So usually for most breast cancer diagnoses, ladies will be having their screening mammogram and they'll be flagged for a certain lesion. And not every lesion on a breast, on a mammogram that's abnormal is cancer, but sometimes some of these lesions either need follow-up in 3 to 6 months, or we recommend a biopsy right then and there. So if a biopsy is positive, usually a radiologist will be the one doing the biopsy, and then you'll be sent to a team of doctors. So the team is our breast surgeons who basically operate. So unfortunately, even in 2021, there is no non-surgical approach for curing breast cancer. Surgery is part of the mainstay of treatment. You'll also see a medical oncologist like myself. And so I like to call us the primary care of your cancer. We kind of help coordinate and navigate the entire treatment plan. Often most women will also meet with a radiation oncologist and talk about radiation to the breast. And then at Franciscan, we also have nurse navigators to kind of help in the process, social workers, because it can be a very stressful time with a lot of needs outside of the medical portion of treatment, nurses, and overall our cancer care team. And our goal at Franciscan, especially at Woodland where I work, our goal is to work really closely as a team and take care of our patients, because we know it is such a common diagnosis, and having a cancer diagnosis can be just a life-altering moment and a life-altering diagnosis. So what I just wanted to say again, so that we all remember, breast cancer was going to affect 1 in 8 women in her lifetime. And so as we age, that risk does go up. And one thing we do know is that early detection with mammogram saves lives. So early detection means you can find a lesion smaller than it can be palpated or felt on exam. And the smaller the lesion, the easier it is to treat and the better the cure rate. So I recommend everyone get your mammogram, sign up, and we hope to see you there.
Okay, a lot of important information, and we're also getting some questions in the chat box and in the Q&A box. Don't forget to put your questions in there for us to ask at the end of the webinar. We're going to take a short break and ask another poll question. How many women are diagnosed with reproductive cancers annually? A, 500,000, B, 250,000, C, 100,000, D, 75,000. Plug in your votes. And the answer is actually C. About 100,000 women will be diagnosed with a variety of reproductive cancers every year. That's enough to fill Lucas Oil Stadium 1.5 times. Now here's Dr. Mahngar to break it down for us.
All right, so let's talk about reproductive cancers. And when we talk about reproductive cancers, we are talking about cancers of the women's reproductive organs. So the ovaries, fallopian tubes, uterus, vulva, and vagina, and the cervix. So when we look again at this 2013 American Cancer Society image, we can see that uterine cancer, if we look at 100,000, about half of those 100,000, about 49,000 cases are going to be uterine cancer. So uterine cancer is the most common type of reproductive cancer in women, and it accounts for about 6% of cancers in women. Now, if you look a little bit further down, the next most common reproductive cancer is ovarian cancer. And this actually includes the ovaries and the fallopian tube. It's about 22,000 women that are diagnosed each year, and that's about 3% of all female cancers. Now, if we move to the right side and we look at our estimated deaths, unfortunately, about 14,000 women pass away every year of ovarian cancer. And so while it's only 3% of the incidence, it actually accounts for 5% of the deaths. On the flip side, uterine cancer, while it is about 6% of the diagnoses, it accounts for about 3% of cancer deaths. About 8,000 women pass away every year from uterine cancer. So as we talked about 100,000 women are diagnosed annually with reproductive cancers, and more than half of these are going to be uterine cancer, then followed by ovarian cancer, and then cervical cancer. So if we do a really quick anatomy session when we're looking here, so the ovaries are on the outside where eggs are released from, and then they travel into the fallopian tube. So ovarian and fallopian tube cancers are actually put into one. Fallopian tube cancer itself is quite uncommon, and so that and the pathology is very similar to ovarian cancer, and it's treated very similarly, so it's kind of categorized in the same. And then uterine cancer is of the uterus itself. Then that opening of the uterus, the cervix at the bottom, is another common form. And then uncommonly, we can have cancers of the vagina, which is basically the vaginal tract. And then we look at the bottom here, this is the vulva, where the vagina actually connects to the outer surfaces. And that is a very uncommon cancer as well. So let's talk about risk factors for uterine and ovarian cancers, because these are the two most common types. So for uterine cancer, we know that obesity or having a BMI greater than 30 is a risk factor for uterine cancer. And similar to breast cancer, the thought is that there's an increase in estrogen with obesity. So extra fat cells will actually secrete estrogen, and estrogen stimulates the uterine lining the same way that it stimulates breast tissue. So we know that obesity is linked, and we're similarly in the next line, estrogen hormones. So again, we learned from the 1990s and early 2000s that women that were getting hormone replacement therapy after menopause were having increased risks and incidences of uterine cancer and breast cancer. And so what we know is that extra estrogen hormone was basically stimulating the lining of the uterus and causing cancer. The next thing is we know that age. Uterine cancer is uncommonly diagnosed for women before menopause. It's usually something we see after menopause. And so again, as we get older, our cells tend to age a little bit. They don't repair quite as well. And so that increases the risk of errors basically, and that's what can cause cancer. The next thing is type 2 diabetes and poor sugar control. We don't quite understand this mechanism, but we think it's basically related to hormone regulation of estrogen again. And then the next thing is if you have family members with uterine cancer and colon cancer, this could increase your risk of uterine cancer itself. So if you have multiple first degree family members, again, parents, siblings, or children with uterine or colon cancer, just make sure it's something that you've addressed with your primary care doctor so they can talk to you a little bit further about it. And then the last thing, and a very, very important thing I want to talk about, is any abnormal bleeding from the uterus into the vagina that you notice after menopause is a red flag for uterine cancer. Now, that doesn't mean that anyone who has postmenopausal bleeding has uterine cancer, but it definitely means we have to assess this. And the mechanism basically is that, as uterine tissue grows and becomes cancerous, that extra cancerous tissue will start to bleed and it'll start to fall off and come out through the vagina. So it's a very common sign of uterine cancer itself. And actually, the bleeding is actually one of the reasons we detect uterine cancer earlier than we detect, say, ovarian cancer, which I'll talk about, because what we try to educate is that most women will come in if they have abnormal bleeding after menopause, and that abnormal bleeding is usually from a stage 1 early stage uterine cancer that's starting to shed already. And so if you do have any abnormal bleeding and you are postmenopausal, you haven't had a period in over a year, that is something to bring up with your primary care to get assessed further. So let's move over to ovarian cancer. Similarly to breast cancer and uterine cancer, we know that obesity, because of those fat cells increasing estrogen, can increase the risk of ovarian cancer. The next thing is childbirth late in life, again, over the age of 30, or not having any children. And again, this has to do with cycle regulation, hormone regulation, leading to that increased stimulus. And then again, as we talked about, hormone replacement or estrogen therapy during menopause. So again, those extra hormones are going to be increasing or stimulating the ovaries, and anything that's stimulating your ovaries extra can increase the risk of a cancer error. Another really important one is a family history of ovarian cancer. We know that about anywhere from 10 to 15% of women up to 20% in some cohorts of women that have ovarian cancer have a gene in their bloodstream or in their DNA that increases the risk of ovarian cancer. And actually now we are recommending that every woman who's diagnosed with ovarian cancer be tested, have genetic testing to see, is she one of those carriers, because it has meaningful information for family. On the flip side, sometimes, people do not want to get tested, or family members, grandma had ovarian cancer 50 years ago and, wasn't tested then. So if you have a family member that has had ovarian cancer, you actually yourself would also qualify for genetic testing as a first degree relative. So if that's something that hasn't been done, but there's a risk in your family, I would recommend talking to your PCP about it, and they can kind of lead you further. And then the last thing we know about is smoking. So smoking is a carcinogen. Basically what it does is it increases the risk of error and free radicals in the body, which increases cancer. And we know that it's linked to an increased risk of ovarian cancer. So the most important things you can kind of do in terms of decreasing your risk of uterine cancer, ovarian cancer. Now, unfortunately, there are not standardized tests like mammograms or colonoscopies for these cancers, because as you saw, they're a lot less common than breast cancer. And we did a lot of trials doing testing. Should we scan ladies' abdomens? Should we do these blood tests? And we found that not only were we not detecting uterine or reproductive cancers, but they usually weren't changing ladies' course of treatment. And a lot of times we were doing extra testing, CT scans that can have their own risks and side effects without actually detecting cancers earlier and without actually improving survival. So for these reasons, a lot of cancers do not have screening mechanisms. It's usually cancers that are very common that have screening mechanisms, such as breast cancer or colon cancer. But some kind of warning signs or risk factors potentially for reproductive cancers are the following. So if you have vaginal or abnormal bleeding after menopause, again, that's very important that you see your primary care and talk to them about that, because that is a risk for uterine cancer. The next thing is very subjective, but a lot of times women can have unexplained persistent abdominal bloating. And so a lot of the times that's usually related to the gut. If you ate something, you're constipated, or, XYZ, you go on vacation and have too many bad foods. But if you're having persistent abdominal bloating that's unexplained by your bowels and it's been going on for a couple of weeks, I would recommend that you get tested or get seen by your doctor for evaluation for ovarian cancer. We know that almost half of women that are diagnosed with ovarian cancer have this symptom. And of course, it's very nonspecific, but if it's something that's been going on and it's not like your usual bloating from, eating something that you're not supposed to eat, or, it's not related to your gut, and you just feel like this is different, I would definitely recommend that you go ahead and see your primary care provider. The next thing is if you're having weight loss. So unexplained weight loss is always a little bit of a concern for cancer. And by unexplained, we mean you weren't trying to diet, you haven't been trying to exercise, you've been just doing what you do regularly and you lost weight. And by weight, we say about 5% of your body weight. So for a woman who weighs 100 pounds, that would be 5 pounds. Or for a woman who weighs 200 pounds, that would be 10 pounds that you just lost, but you weren't trying to, and it just doesn't quite make sense. So if that happens, I would definitely see your doctor, and they can kind of work you up and make sure there isn't some undiagnosed malignancy. And then the last thing I would recommend that you talk to your doctor about is if you have a family history of ovarian cancer, so mom, grandma, sisters, or daughters have been diagnosed with ovarian cancer, or you have a family history of uterine and colon cancers in your family. Those are signs of potentially genetic syndromes in the family, and it's important to potentially talk about getting tested to see, are you at increased risk for these cancers, and what can we do from that standpoint? All right, so I'm going to talk a little bit about treatment options for these cancers. This is a kind of a vague slide because every cancer treatment is very personalized to the patient, and every patient is unique. But for most patients that have a reproductive cancer, they always see a gynecological oncologist. And so this is a specialized gynecologist who only specializes in oncology or cancer, and they only do cancer surgeries of the reproductive organs. And there was actually a study done comparing, not that regular gynecologists gynecologists are fantastic at what they do, but comparing regular gynecologists and gynecological oncologists, comparing the two, and we know that our gynecological oncologists do better surgeries, are able to resect more cancer, and they have better survival rates. So usually the first step is usually always surgery and removal of reproductive parts, and that will show us the actual stage of the cancer. Has it spread from the ovary or the uterus? Is it only contained to that area? And so they are usually the first person that you meet with. For cancers that are more advanced, meaning beyond a stage 1 cancer, so stage 2, 3, and 4, and again, this very much depends on the type of cancer and what was removed. We do sometimes recommend adjuvant means after chemotherapy and or radiation for more advanced patients. And then the last thing I'd like to bring up is stage 1 uterine cancer is highly curable and it rarely recurs. So stage 1 uterine cancer is early stage. It's confined just to the uterus, usually presents with vaginal bleeding after menopause. And those women usually will have a hysterectomy done. And usually in most cases, in almost 60% of cases, we'll see that the tumor has not infiltrated the first half of the uterus. And for those patients, we don't recommend any more treatment afterwards, and they are very unlikely to recur. So I know that was a lot of information. I think we have a couple of comments coming in. So if you have any questions, please let me know. I think we have quite a bit of time for questions. So that is the end of my portion, but I'm happy to answer anything that could have popped up for you along the way.
Hey, well, thank you, Dr. Mahngar, for unpacking a lot of information for us and making it a little bit easier to understand. So, yes, we're going to take questions now. I have been packing up some of those questions to read to you. So, starting off, someone did ask, how often should women get our mammograms?
That's a good question. So for most women over the age of 40, we recommend an annual mammogram. However, when you have your first mammogram, sometimes if you have dense breast tissue or for XYZ reason, we'll recommend that you have a mammogram done, 6 months later. But for most people, it's about once a year. What is really nice about Franciscan is that when you get your mammograms before you leave, they'll actually tell you, hey, things look good, mammogram again in 6 months or 1 year, or hey, we need to do an ultrasound or we need to do a little bit more imaging. So you'll have that information before you even leave for the mammogram.
Thank you so much. Someone else had asked, is there an advantage to getting an MRI when getting a possible breast cancer diagnosis?
That is a really good question, and not always. So for breast cancer, for our most common types of breast cancer, generally for tumors that are less than a centimeter, and that's usually what we diagnose on mammograms, especially women coming annually. Usually the mammogram is sufficient. Now, sometimes for ladies that have lobular carcinoma, which I talked about, so those were the grapes that we looked at leading to the ducts, lobular carcinomas can hide a little bit on a mammogram, and so for those patients, we recommend getting an MRI also, just to make sure we're not missing anything. But generally, the beauty of a mammogram is that we are able to see for most cancers almost the entire architecture, and we're able to go successfully to surgery just based on the mammogram. Now, the other caveat is for ladies that have really dense breast tissue and they can't see everything on a mammogram, sometimes we'll recommend an MRI to kind of take a better look, but that's pretty uncommon. So for most people, we are able to get everything we need from a mammogram, but there are some exceptions to that where an MRI can give us a little bit more information.
Okay, thank you so much. At what age should women stop getting mammograms and PAPs?
So that is a good question. So that is a loaded question. There are definitely guidelines, but what I say to women is if you have 5 or 10 years to live, you should be getting a mammogram. So I have a 90-year-old in my clinic. She drives, she goes to Florida in the winters. She probably has more energy than I do, which is quite amazing. And so technically the guidelines say she does not need to get mammograms, but I do not think that this woman is going to pass away in the next 5 or 10 years. She's doing great. She's on no medications. And so she is getting her annual mammogram. So it's more like, how much benefit can you get from getting a mammogram? Now, some women who are a little bit more elderly, a little bit more frail, they wouldn't be able to go through things like surgery or treatment, or, they are in the last several years of their life. At that point, it's probably reasonable to stop getting mammograms.
Okay. Now, someone asked, is the reduced use of hormone therapy after menopause the main reason for that reduction in death from 70,000 to 40,000?
That's a good question. That's definitely part of it. Unfortunately, there are still quite a few women that are using hormone therapy. Some of it is just, comfort with the therapy. They know there's a risk of breast cancer, but they just, cannot live off of hormone therapy because their symptoms are so bad. What we have studied is really mammograms. So we think the most common cause of reduction in mortality is actually mammograms themselves, because what we're doing is detecting breast cancers at an earlier size, and then they're more curable in that sense. So it seems like probably at least 30 to 40% of that weight is from mammograms, but certainly women who are having less hormone therapy now are also getting less breast cancers.
Okay. Someone asked, and I don't know if I'm saying this right, anastrozole. She says 5 years or 10 years. I'm at the 5-year mark. How effective is it?
That's a great question. This is actually something I talk to all my patients in clinic because it's still kind of a question mark. So anastrozole, for those of you who don't know, is a hormone blocker, and it blocks estrogen. So what we talked about is we know estrogen increases breast cancer. And if you have a type of breast cancer that expresses estrogen, or ER positive, which is the most common type of breast cancer, we give a medication like anastrozole. And until a couple of years ago, we were recommending everyone take it for 5 years. And we started to see some new data. Well, we're still seeing some people recur after 5 years. So is it beneficial to take it longer? So right now, the kind of general consensus in oncology is for ladies that had large tumors, more than 5 centimeters in size, or who that positive lymph nodes, or who needed a lot of chemotherapy after their cancer. So one of those things, meaning these are all things that increase the risk, right? Larger size of the mass, spread to the lymph nodes, or needing chemotherapy. These are all things that that allude to a higher risk breast cancer. Those patients that may actually benefit from 10 years of hormone replacement therapy. So for some of my patients, if they are tolerated, okay, we do talk about doing 10 years. What I kind of tell all my patients is let's wait till you get to your 5-year mark, and then we'll see what the most updated data is. So I have some ladies who are a year or two in, and this data is still evolving right now, because as you can imagine, it takes about 10, 15 years for this data for us to look back and say, okay, who had the benefit? So what I've been telling most of my patients is, who are kind of borderline, maybe they needed to have chemo after, their breast cancer, but they had a smaller tumor, or they didn't have positive lymph nodes, or they had one positive lymph node, but they didn't need chemotherapy. These kind of intermediate cases, I kind of say, when you get to your 5 years, let's see what the most recent data is and how much of a benefit there is, and we'll go from there. Now, we think for ladies that have low risk breast cancers that are on anastrozole for 5 years, there probably is less than a 1% benefit of doing anastrozole more than 5 years. So for those patients, of course, all medicines have risks. So that's kind of a risk benefit. But what I'm basically saying to most of my patients is, once we get to your 5 years, let me see what the most recent data is, and we'll go from there. Because even from 3 years ago, it's changed. And so it's going to keep evolving.
Oh, thank you so much for answering that. Someone asked, how are men actually diagnosed with breast cancer? Is that different than females?
Yeah, that's a great question. So usually men will feel a lump kind of around the pectoralis. So men do have breast tissue. It's just much smaller than women. They have smaller volume. So because they have less breast tissue, they're less likely to get breast cancer. And so usually they'll see like a lump or a knot kind of on their chest. And so hopefully that triggers them to talk to a family member or provider. And then usually they'll have an ultrasound done of that area where they'll be able to see if something is concerning that needs to be biopsied or evaluated.
Okay, thank you. Someone asked, should you keep getting pap smears after menopause and hysterectomies?
So for the hysterectomy question, so generally now we do full hysterectomies where the cervix is removed. So if your cervix is removed at the time of your surgery, you do not have to have any more pap smears. And then generally for postmenopausal women, if you've been up to date with your pap smears until then, you don't need to have any further pap smears because the risk of cervical cancer declines pretty significantly at that point.
Thank you so much. Someone asked, can you please explain LCIS, an LCIS diagnosis?
Sure. So LCIS is basically lobular carcinoma in situ. So it's a fancy, Greek terminology for precancerous lesion. So lobular carcinoma, again, remember we talked about the lobules that lead the grapes that lead to the ducts that lead to the nipple. So lobular carcinoma in situ means precancerous. So these are precancerous cells that can be found in the breast. And we know that these women are at increased risk of breast cancer. There's another flavor called ductal carcinoma in situ, same thing. They're precancerous lesions of the duct. And so those cells are absolutely going to turn into cancer at some point. So for ductal carcinoma in situ, we recommend that the lesions be removed. For LCIS, it's a little bit different. Unless you have a very aggressive type of LCIS on a biopsy or something called a pleomorphic LCIS, a lot of times we can watch those lesions and we can spare a woman from surgery and we can give hormone blockade to kind of watch over time. But basically it is a precancerous lesion, and that can increase a woman's risk of breast cancer down the road.
Okay, thank you so much. We have someone who asks, how much does dual family history of breast cancer and colon cancer increase overall risk of developing some type of cancer?
That's a good question. It very much depends on the ages people are diagnosed. So we know that for most genetic syndromes of breast cancer, most women are going to be diagnosed before the age of 60. Usually it's before the age of 50. And then same thing for colon cancer. Most colon cancers that are increased incidence in families are before the age of 60. So if you have multiple family members with both of those cancers, I would say it increases that risk. And it's a good idea to basically map out a family tree and talk to your primary care provider about it. And so you can go through, okay, mom was this age, because it's not only just this is actually a really great question, because it's not only just the family history, but it's the ages of people who are diagnosed, because we know with genetic syndromes or genes that are off in the body, those people are generally diagnosed at earlier ages. So, if you have a family member who is diagnosed with breast cancer at 85, that is a little bit of a different risk than, let's say, your sister was diagnosed at the age of 30. That risk is, a little bit up. So those things are all into play. So what I tell people to do is, talk to your family, figure out kind of family tree, who had cancer when and what ages they had it, and then bring it into your primary care. Because as you kind of alluded to, multiple people with multiple cancers, it can increase the risk of cancers overall.
Okay. So another person has asked, do fibroids increase risk of breast or cervical cancer?
So that is a good question. Fibroids are, I think this person is alluding to fibroids in the uterus. Fibroids in the uterus are usually benign tissue in the uterus or growths. Sometimes if they look large or atypical, that can increase the risk. Fibroids should not increase the risk of cervical cancer. And then in terms of breast, we can definitely have cystic disease in our breast. So a lot of women, we have lobules, ducts, and go into the nipple, but we can have different fibrous areas, fibroadenomas, and other things that are basically just different anatomy of the breast. And those should not increase the risk of breast cancer.
Thank you. Another person, we're getting great questions. Someone else asked, can one-time bleeding and increased size in endometrial lining after an ablation for a woman in menopause in her 50s be an indication of cancer?
So anyone who's had an endometrial ablation, usually, so I think what this question is asking is if I had some bleeding after my endometrial ablation. In that situation, usually you'll have a little bit of bleeding after that procedure. But if it's persistent, I think that is something that can increase the risk. If you have a thickened endometrial lining, but it generally is being monitored by someone. So I would just kind of keep an eye on that. But generally a one-time bleeding after an ablation, that is basically because they're ablating that lining. And so you're going to have a little bit of bleeding.
What about vulvar cancer? Are there preventive testing for that, and what causes the vulvar squamous cell cancers?
That's a really good question. Vulvar cancer is pretty uncommon, and it's basically the type of cancer we see is called squamous cell cancer. So what we'll see is like a lesion or a wart, and the vulva is the outside of the vagina. So what I tell all women to do is just take a look at that area and make sure there's nothing abnormal. But similarly, if you were to see a skin cancer lesion, like an ulcer or a lesion like that, that can be concerning. So that is something that can increase the risk. Vulvar cancer is usually linked to increased age. So as women have vaginal dryness and vulvar dryness, they can have more irritation to the area. So that can be an increased risk. And so vulvar cancer is commonly diagnosed in older women and pretty uncommon in young women.
Thank you. Someone asked, is triple negative breast cancer that is resistant to chemotherapy still curable?
That is a really good question. Triple negative breast cancer is changing so much right now. There's actually some new treatment options, including immunotherapy. And for patients who are BRCA 1 or 2 positive, which is a type of genetic syndrome that can lead to triple negative breast cancer, there are actually pills that we can give. Unfortunately, so most breast cancers respond well to chemotherapy, including triple negative. And sometimes what we'll do is we'll give chemo before patients have surgery for triple negative breast cancer. Sometimes the tumor can be resistant to this kind of treatment, but that doesn't necessarily mean it's not curable. It just means we proceed next to surgery and then we do radiation afterwards. So while it's uncommon for triple negative breast cancers to be resistant to chemotherapy, it doesn't necessarily mean that they're not curable.
Okay, so that leads to another good question we have. Can you kind of explain a little bit about how immunotherapy is used and how it's used to treat these cancers?
Sure. So immunotherapy is basically kind of the new thing in oncology. It's really exciting as an oncologist because it is a type of treatment we can offer that it has a lot less side effects than chemo. So the thought is that a lot of cancers, why do older people get cancer? So we talked about the older you are, the more errors you have in your tissue and the more likely you are to have a mutation. But another phenomenon is that as we get older, our immune system isn't as good. And so our immune system, not only does it fight infections, but it can also fight anything abnormal in the body, like an abnormal cell that could turn into cancer. And so as we get older, our immune system can get a little bit sleepy, and these precancerous cells or these cancerous cells can get smart and they can put a blindfold on your immune system. So your immune system is blind, it's not functioning well, it can't get rid of these very small cancer cells or precancerous cells. What immunotherapy does is it basically boosts your own immune system. It takes that blindfold off so that your own immune system can find the cancer cells and kill them along with other treatments. Immunotherapy actually is kind of changing the landscape of cancer entirely, because I know this isn't a lung cancer talk, but we're actually seeing a small percentage of patients with what we thought was incurable lung cancer, going into remissions uncommonly, with immunotherapy. And so what immunotherapy does is it turns on that immune system. And the benefit is sometimes people can have just a fantastic response. And we're starting to incorporate it with triple negative breast cancer in the metastatic setting or stage 4 setting. And for now, patients who are getting chemotherapy, we can also add immunotherapy to their treatment options. It's not being used as much in uterine or cervical cancer. For patients that have unresectable or uncurable uterine and cervical cancers, there is an option for immunotherapy if they have a certain blood test that shows that their immune system has a blindfold on. And so it's not used quite as commonly, but it is starting to be used a lot more in breast cancer at this point. And it's as an oncologist, it's kind of fascinating because when I was in training, these things were being studied and they're still being studied now, but now they're actually in the live. So it's kind of exciting as an oncologist to see things that, were being created. The Nobel Prize for Science, I think in 2016 was for immunotherapy. And now it's one of our mainstay treatments. And so to see that evolution and to see more treatment options for people is really exciting. The other nice thing about immunotherapy is for most patients, it doesn't have a lot of side effects. So the side effects are it boosts your immune system. So sometimes your immune system can get too excited and it can act up in that way. And that's about in 1 in 5 patients. But for a lot of patients, they don't have side effects like they would with chemotherapy, with immune therapy. And so that is another kind of advantage to it.
Okay, great. Well, that leads to another question. Someone was asking if you could talk a little bit about the recurrence of breast cancer.
Sure. So breast cancer recurrence basically depends on the type of cancer and the size. So the smaller a tumor is initially when it's diagnosed, again, this is why mammograms are so important, the less likely it is to recur. But tumors that are larger or have a lot of lymph nodes that are positive, they can recur. Now there's 2 types of recurrences. One is, and this is the more common one, is it can recur somewhere outside of the breast. So in the lung or the bone or the brain. And unfortunately, in these cases, this is not a curable disease, and it's something that we have to try to control the best we can. Rarely you can get a recurrence in the same breast, and then sometimes you can get a recurrence in the other breast, but usually that's not a recurrence, it's usually a second breast cancer.
Okay, we have about 5 more minutes, so I know we've got some other questions to cover. We'll try to cover as many as we can in the next 5 minutes. So we had someone that asked if you could talk a little bit about the recurrence actually of ovarian cancer. Would it be treated the same if you got it a second time?
So that's a really good question. Most of the time ovarian cancer, so initially for ovarian cancer, in 2021, we removed both ovaries, the fallopian tubes, the uterus, lymph nodes. We remove everything because we want to look at it all and see where all of this ovarian cancer spread to. So, and then based on the stage, we'll give treatment afterwards too. Ovarian cancer, if it is to recur, in most situations is not curable. If there's a small amount of disease and, and this is where we have a tumor board discussion where all the doctors talk together. Sometimes you can do the same treatment where you basically resect the tumor again and can do more treatment. If it recurs within 6 months of your initial treatment, then it's a little bit more of an aggressive tumor. And then we have to kind of put on different hats and treat it a little bit differently. And so the thing about ovarian cancer recurrence is the sooner it recurs, if it's to recur, the sooner it recurs to when you were diagnosed, the more aggressive it is. Generally, recurrences that happen years and years later tend to be more slow growing and tend to have more options basically. So if you recur later, more than 6 months or a year after, then yes, we can do surgery and then chemotherapy afterwards. The same thing we did initially, but if it recurs within 6 months, that is when it's, unlikely that surgery would have benefit just based on the biology of the tumor.
Thank you. Someone asked, would vulvar squamous cancer in older women who do not get pelvic exams but are at risk, could they look to their PCP if they're at risk? She said, my mother had 3 gynecologic cancers and died of vulvar cancer, and I worry about this ugly disease.
I'm really sorry to hear about your mother. It's never easy to lose someone to cancer. I think, if you're not comfortable doing a pelvic exam on your own, it is important just to have your PCP take a look. Again, these, cancers are pretty uncommon. And for vulvar cancer, we do not know of a genetic link at this point that increases the risk in like mother to daughter and necessarily like we do in breast cancer or ovarian cancer. But it's definitely important to just get examined. And so it's something I definitely recommend talking to your PCP and seeing if you can have an exam done. And if your PCP is uncomfortable, they can definitely, gynecology can definitely examine you as well and kind of teach you ways to actually do exams at home with a mirror, basically.
Okay, thank you. I think we have time for just a couple of more questions. We had several different people who asked if you could explain how breast cancers or ovarian cancer, any of those cancers, are staged.
So let's talk kind of about breast cancer first. Breast cancer is staged by something called our T&M staging. So T is the primary tumor, T for tumor, how big is that tumor? And so for breast cancer, it can be less than 2 centimeters, 2 to 5 centimeters, 5 and beyond. That's the T stage. Your N stage is how many lymph nodes are positive. So when you get your mammogram done, it also looks at the armpit area, which is where the lymph nodes will be. If you have a positive lymph node, it stages you up to stage 2 cancer. So if you just have a primary tumor in the breast that's small, it's a stage 1. If the tumor in the breast is larger than 5 centimeters or you have a positive lymph node, it's going to be a stage 2 cancer. If you have multiple lymph nodes, 5, 6, 7, 8 in the armpit that are positive, that would make it a stage 3 cancer. And then stage 4 breast cancer is unfortunately if it's spread to outside of the breast, so like the lungs or the bones. When we talk about ovarian cancer is staged based on where it is spread. Again, so stage 1 ovarian cancer is it's just confined to that ovary. Stage 2 is it can be in both ovaries or local areas. Stage 3 is it's invading into the uterus or local structures or lymph nodes in the area. And then stage 4 is that it's spread beyond the pelvis into somewhere kind of further north, so like the lungs or places like that.
Okay, and I think this is going to be our last question. Someone asked, what are your thoughts on taking part in a clinical trial?
That is a good question. For patients who are diagnosed with cancer, clinical trials are always an option. We know that the future of oncology is in clinical trials. There are stuff that we do now because there were trials done a decade ago, like immunotherapy. There were trials a decade ago. Unfortunately, Franciscan has a lot of clinical trials for patients. And the nice thing is that most of these clinical trials, so we offer them, here, we offer them in Indianapolis. The nice thing is that those trials can basically give you an additional medication. So usually the trials will still do the standard of care. So what is done, what is done nationally, and what's the standard of care for this cancer, and it'll add another treatment to it. Now, what is tricky about clinical trials is we don't always know if the thing we're adding is beneficial. So sometimes we could be adding something that has more side effects that may not be of benefit. But sometimes, it's good to talk to your doctor about it, because sometimes we'll be adding something that we kind of all know, like we've seen in other trials that it's helpful. And so sometimes I encourage patients. So for example, immunotherapy in a certain sequence was just getting approved at the beginning of this year. And one of my patients, she's very young. And I told her, like, let's get you enrolled in this trial unless it closes, because I think this is going to be a positive trial. And actually in June, when she was eligible, the trial had closed because it was a positive trial. And then we added that treatment as standard of care. So sometimes your provider will know what their suspicion is, that this would be a beneficial trial or not. But again, these trials are designed to basically help us answer more questions, to increase cure rates, to increase treatment options. So I think clinical trials are great, but it's definitely something to talk with your doctor about, because they don't always provide a benefit, but they definitely can in some situations.
Okay, thank you so much. And we want to be respectful of your time, and it is 7:31 now. So if we didn't get to your questions, we're so sorry. We still have some left, but we're unable to get to those this evening. But we have come to the end of our time together, and we want to thank Dr. Mahngar for sharing all this great information. And we want to thank each of you for attending this evening's webinar on better understanding cancer in women. We understand that your time is valuable as well, so we thank you for prioritizing your health to spend time with us this evening. And once again, we'll send an email with the recording of this session, and you can feel free to watch it again, share it with others who you think might find it helpful. You'll also receive a survey about the seminar and its content. Your feedback is really important to us, so it helps us to make better seminars in the future. So please take a few moments to complete that if you could. And on behalf of everyone at Franciscan Health, we thank you for being with us, and have a blessed and beautiful evening.